Welcome everyone to the Animal Heartbeat, your veterinary cardiology podcast. I'm Jose and I'm here as always with Kieran Borjay, my podcast buddy. Hi Kieran, how are you doing today?
Hey Jose, great. Super excited about this episode.
Absolutely. We'll be talking today about congestive heart failure, diuretics and assessment of treatment efficacy. And we are honored to have with us today Professor Mark Oyama. Mark is a professor of veterinary cardiology at the University of Pennsylvania School of Veterinary Medicine, chair of the Department of Clinical Sciences and Advanced Medicine, the Charlotte Newton Shepherd Endowed Chair of Medicine, and Mark is also an associate scholar at the Center of Clinical Epidemiology and Biostatistics. Mark has been publishing widely in veterinary cardiology and most recently in congestive heart failure monitoring. Mark, thanks very much for joining us today.
Well, thanks for having me. I appreciate it. It's a unique podcast you guys have, and I'm glad it's been successful.
Congestive heart failure is a clinical syndrome caused by a heart disease, which is characterized by an abnormal sodium and water retention resulting in edema, congestive signs. Loop diuretics are our mainstay treatment for congestive heart failure. The two loop diuretics we use is furosemide and most recently furosemide. What are the potential advantages of furosemide in comparison with furosemide?
So, there are some theoretic advantages. There's some practical advantages. They're both loop diuretics, so they're going to act, in a similar fashion within the kidney, but there's some, pharmacodynamic, pharmacokinetic differences that may be an advantage. So one is the longer half-life of torsemide compared to furosemide. So you'll notice that it's, labeled for once a day dosing versus, at least twice a day we typically do for furosemide. There's a little bit more consistent GI absorption. So that might be an advantage, especially as you're trying to change doses or in animals that have right heart failure that you think that, oral absorption of drugs is going to be impaired. There used to be, and maybe there still is, some thought that torsemide also has some anti-aldosterone receptor blocker. Most of that has probably gone by the wayside, and so how important that is a little bit up for debate. On a milligram, of drug basis, it's more potent than furosemide. That could be thought of as potentially as an advantage, but it's really just how you dose it, right? So you can have equivalent amount of diuretic action if you just simply increase the doses, for instance, of furosemide, given that, the pharmacodynamics and pharmacokinetics are the same, but you typically are giving smaller doses, and maybe that means you have more room to increase. Historically, there hasn't been a lot of head-to-head comparison, even in human medicine, between the two in terms of efficacy. The study that until very recently that was most cited was an uncontrolled sort of open label sort of study where people on torsemide lived longer and did better than on furosemide. That was sort of the best evidence out there for a long period of time, but it wasn't a real rigorous randomized controlled trial. So I don't know if you guys were familiar with a relatively recent trial, something called Transform Heart Failure. But, that was a prospective trial. It was sort of a, pragmatic trial in that they were looking really just at survival. And they tried to do it with a lot of people relatively inexpensively and with not a lot of, administrative and procedural burden in terms of monitoring the patients. So they really just looked at mortality. To many of us, to me, very, very disappointingly, there wasn't a difference in mortality between torsemide as sort of a first line diuretic versus furosemide. So that might dampen the enthusiasm a little bit on the veterinary side in terms of distinct survival advantages. In my mind, those are the sort of things to think about when you're thinking about torsemide.
So in terms of what you would reach for as a first line, do you reach for furosemide, torsemide, or does it depend on the case?
I would say prior to Transform Heart Failure, I would not be opposed to doing torsemide as the very first drug. Sure. And the balance there would be we're less familiar with it, so it's less intuitive about the dose to pick, right? Versus furosemide, like we can all be relatively successful about picking doses of furosemide for, various levels of heart failure. We're less intuitive with torsemide, but I think I'd be willing to make that trade if I thought there was a survival benefit. I would say, I think using furosemide as a front line is still extremely reasonable. I think it's also reasonable to use torsemide as a front line. I think what that Transform study showed is that you can be successful with either.
There's certainly sufficient safety data in dogs, isn't there, to say that it's not higher risk of renal injury or something like that, at least in the short term.
Yeah. I think that where you could get into trouble, again, is just your familiarity with dose, right? So you're giving a diuretic. I mean, if you dose furosemide too high, you're going to have azotemia and you're going to have problems, right? And so the plus and minus of the torsemide is that it is more potent. But the minus might be that it is more potent, right? So you have maybe a little bit less wiggle room for your dose, and that if you pick a dose that's too high, then you're going to cause a lot of dehydration and pre-renal azotemia. And in terms of catastrophic renal failure happening, it's extremely rare that we would do that with furosemide, and I think it's extremely rare that you would do that with torsemide as well. You just have to pay attention, like you always do, right, to dogs' clinical signs and hydration status, renal function, and the owner being real careful at home to make sure they alert you if there's a change in the dog's appetite, et cetera, et cetera.
Regarding trials, you mentioned the Transform heart failure trial in humans, and you have done a clinical trial in dogs, the Carpodium trial, which was a double-blinded, randomized, non-inferiority study. So comparing oral furosemide with torsemide, and of course, being a non-inferiority study, the best that the new drug can do is to be the same or not worse than the gold standard. On that study, as Kieran was saying, you prove that torsemide is safe, is as efficient as furosemide. But then on the sub-analysis, there was some suggestion that potentially on that data, on that cohort, that maybe torsemide could be better or could be more advantageous, because you had some suggestions that maybe decrease the risk of cardiac death and worsening congestive heart failure. Of course, the study was not designed to evaluate cardiac death and so on, but is that at least hypothesis generating and something to pursue, and then to have a similar study in humans? So just a similar study in dogs as the Transform study in humans.
Yeah, so I mean that's a great point. So just like you said, that suggestion of improved outcome was not a primary endpoint of that study, but it was there, and there was a similar finding in a study by the group out of France, a similar and very similar sort of numerical, quantitative risk reduction. And I think here's my opinion on some of that, I guess. Certainly, had Transform heart failure been compelling on the side of torsemide, right, then there's huge amounts of momentum from from many different avenues, right, to pursue that. The result in people does not necessarily mean it's going to be the same in dogs, although maybe it's less likely, right, if it doesn't work out in people. I mean, a lot of the physiology is the same, but it's certainly not apples to apples. Mm-hmm. The one thing that I think that we can't account for in the human studies that is a big driver of mortality, right, in the veterinary studies is the issue about euthanasia and people's threshold for when they do that, right? And so it's my belief that one of the things that makes people euthanize is recurrent hospitalizations for heart failure. And so the risk of an animal dying or being put to sleep because of recurrent heart failure episodes, I think, is very, very high. And in fact, most of the outcomes we see in all of the studies, right, we had these composite outcomes. The majority of the outcomes is quote unquote treatment failure, where you're struggling to control heart failure rather than the animal actually dies. So if treatment failure or hospitalization is a driver for euthanasia, and you can prevent hospitalizations with X drug, maybe that's torsemide, then I think it's not unreasonable to believe that you're going to reduce the risk of that dog dying because it's doing well at home and the owner's not going to be thinking about euthanasia versus in the hospital. And now it's, stressful for the owner, stressful for the dog. And then there's the financial burden, right, of having to treat that dog's acute heart failure episode. So the Transform didn't show that there was a reduction in hospitalization that was very neutral between the two. But, again, that doesn't preclude the fact that torsemide, if it does reduce hospitalization in dogs, I think that could possibly have a survival benefit.
I think the reasons for seeking hospital attention for dogs with heart failure are quite different to humans, aren't they? And I completely agree about the burden on the owner and the pet owner relationship of that repeated heart failure, escalating diuretic doses, visits to hospital. Diuretic resistance is a massive problem in time, I think, in all our cases, isn't it? What are your strategies to try and, I guess, number one, assess diuretic resistance, and number two, deal with that? Let's say a case begins on furosemide.
This is the huge sort of gold ring in terms of how do we assess response to diuretics and efficacy of treatment and reduction of risk of future episodes of congestion or prediction of future episodes of congestion, right? That you can intervene and mitigate that risk, right? Without having to depend on the dog stops eating and is now dyspneic and goes into the hospital. I think a huge fertile area to explore is how do you assess the dog's responsiveness to the diuretics, and when that responsiveness starts to become low, and intervene in the still overtly clinically normal animal so that you have prevented an episode of heart failure in the coming future. So the way I sort of think about it is, if there was a way to tell, in any given dog, when this dog wakes up tomorrow morning, it's going to have some congestion that's going to affect its quality of life. And so what you're going to do the night before is intensify its treatment. And by doing so, you're going to have that dog wake up the next morning and be perfectly fine. So how well can we predict when that's going to happen so that we can do that intervention? That's where myself and a lot of other people are interested in urine sodium and other sort of metrics that all take place, that are all occurring right before there's actual overt congestion and clinical signs. So I guess that's a very long-winded way to answer your question in that, how do you intensify treatment, right? Typically, everybody's going to increase the amount of diuretics because most of the other stuff that we use is a relatively fixed dose. And, most of the data would suggest that the benefit that you get by increasing the other arms of the treatment are low once you reach a certain dose, right? Where that isn't necessarily the case with loop diuretics or stacking on diuretics, right?
Yeah.
And doing those sorts of things. So, it's all on intensification of diuresis. Their diuretic responsiveness comes into play as well. So what's the responsiveness of a dog going from 4 to 6 milligrams per kilogram of furosemide versus what's the responsiveness to switch that dog from 4 milligrams per kilogram to 0.4 milligrams of torsemide, or some combination thereof, or adding a non-loop diuretic like a thiazide diuretic. I think if you ask 10 cardiologists, you'll get 10 different answers, right? There's people that are going to intensify furosemide, and there's people that will stop at 6. There are people that will stop at 12 before they switch over to something.
Right.
There's people that will double the spironolactone dose. There's people that will add thiazide. There's people that will switch totally wholesale from furosemide to torsemide. And there's people that will give furosemide and a little bit of torsemide. And then every combination in between. And where studies I think would be super helpful would be to look at some of the real common strategies and to try to figure out, okay, which of those, both quantitatively restore diuretic resistance and which of those, prevent recurrent hospitalizations for heart failure. Those studies are super hard to do, right?
Oh, yeah.
Mark, if we just step back, because that's such a huge and important subject, but if we look at how we can first quantify diuretic efficacy, would love to hear from you. Then once we define what are the quantitative ways to assess diuretic efficiency, then we can also figure out what the mechanism for resistance is. So if we step back and look at how do we assess diuretic efficiency, and as you were saying, most of us use qualitative subjective measurements. We look at clinical signs, radiographic signs to decide is this patient responding to diuresis or no? And then we tailor our treatment based on that. So we use maybe hydration status, renal values to tailor our furosemide therapy, but that's it. So thinking about quantitative ways to assess diuretic responsiveness, what do they use in humans? What are the quantitative ways to assess the loop diuretic response in people?
Yeah, I mean, at its core, what you're attempting to do with the diuretics is get rid of excess sodium. That's its most sort of simple thing, but then you can, from that little core nugget, you can expand out from there and add additional layers. And that is, okay, well, as you get rid of sodium, you're getting rid of fluid. And then you can start thinking about, well, where am I getting rid of sodium and fluid? Is it in the intervascular space? Is it in the interstitial space? And those are obviously related, but two separate compartments. To me, at least, a really good measure of diuretic responsiveness is how much sodium are you actually getting rid of? And so that's what, a lot of those position papers talk about in people. And so the one that folks that are interested in diuretic resistance constantly quote is the position paper from the European Heart Failure Society, where they talk about using spot urine sodiums and, in some respect, cumulative urine sodiums and urine volumes in the acute period, right, to monitor and to guide subsequent diuretic doses. So there, what they're talking about is, if your urine sodium concentration is less than around, 60, and you also have below a threshold of actual urine output, they're not going to wait 24 hours to see how you're responding if your congestion, clears up in terms of your dyspnea. They're going to intensify the treatment based on those factors and change the treatment based on those factors. Even though two patients might come in and look clinically exactly the same, they're going to have different treatments depending on what that first 6-hour urine sodium looks like. And so I think that's surprisingly, in human medicine, that's a relatively new, novel concept, but one I think that has sort of taken hold. It has gotten a lot of traction and buy-in, across the human cardiology field. And so, I know my colleague at the Yale Medical School, his name's Jeff Testani. I think he spoke at ACVIM one year, who's one of the sort of leaders in this. He tells me about the Yale Heart Failure Clinic, and that's they have a very sort of standardized protocol that they go through that's based on the urine sodiums in terms of how they treat those patients. And so I don't think his practice is an outlier. I think there's more and more cardiology practices and key opinion leaders that embrace that sort of approach. The problem with us veterinarians, right, is the missing piece that we have, and that's the urine volume. So what matters is the total amount of sodium that you are losing. So obviously, the way you get the total amount is it's the concentration in the urine times the urine volume. And, you could take extrapolate a little bit, which is not unreasonable, to say that, given any sort of urine volume, if your urine sodium is low, the total amount of natriuresis you're going to have is going to be less than if your urine sodium concentration is relatively high. That doesn't necessarily have to always be the case, right? You can be excreting zero urine and have super concentrated, and that's not good, right? So in people, obviously, you can quantify their urine output, even though it's relatively hard to do and that people aren't compliant about it, but you can do that. For us, right, it's extremely hard to do that from a practical situation. So we're missing one half of that equation, which makes us more reliant on just the concentration to say whether or not we have resistance or not. So I worry about that a little bit, in that in some cases you're going to be misled by the concentration, but the concentration is a way to quantify it and is better than anything we're doing currently now, which is really honestly nothing.
And what we're doing is late, isn't it? As you say,
yeah, it's super late.
After the congestion has happened, it's after they've sought veterinary advice potentially, and that's not where we want to be, really.
Yeah, by the time that happens, it's too late. You've lost your chance to intervene and prevent hospitalization and prevent morbidity there. So, I think urine sodium, and to some respect, urine chloride also is is going to be something that is super interesting to look at in dogs. And the physiology would suggest that it should be a really good indicator of diuretic resistance. The question just is around what's its variability day to day? How is it affected by diet? How is it affected by timing of when it gets the drugs? And, how strongly correlated is it to total natriuresis, and so on and so forth. So those are all logistical sort of questions that we have to answer. The physiology of why it should reflect diuretic resistance, I think, is super, super sound. And so it's just a matter of how to use the information, how to get and use the information.
Yeah, and it's interesting you talk about compliance in people, because you think that would be straightforward. So if people can't do it for themselves, then doing it for their pet, even forgetting about the practicalities of it, that's makes it very difficult for us to use, doesn't it, in the clinic?
Yeah. And thinking about other quantitative things that you can do, right? So one thing is, weight gain, right? We would expect that as animals retain more and more fluid, or people retain more and more fluid, right, they're going to have an increase in weight. How sensitive we can measure that, and in terms of a small dog versus a person, and stuff like that, in terms of your scale and everything, the day-to-day variability, right, is a question. But even in the best circumstance where you could very accurately weigh yourself or an animal, the studies in people are really compelling that is not a great indicator of you having future congestion. And it's because of just transfer, redistribution of the fluid that you have. And that if that is redistributed into the interstitial space, you can have zero weight gain whatsoever and still have congestion. And the fact that, I forget what the number is, don't quote me on this, but I don't know, it's 30-40% of people, right, that end up with heart failure have no premonitory gain in weight, would indicate, right, that this redistribution is a huge factor in heart failure. So even if we could really accurately weigh animals, it's not going to guarantee that you're going to catch episodes of heart failure, because you can't detect that redistribution.
Yeah, that's so interesting, really. That's just a shift of fluids from one space, interstitium, to intravascular space, and so on, makes a huge difference. Something that was also a bit of a wake-up call for me reading your papers was urine volume doesn't mean necessarily QT decongestion. Certainly, it's difficult practically to measure urine volume, but what we want is sodium in the urine, right? Can you explain that a bit better? Why would a patient may potentially have a large urine volume and is just free water and no solute and sodium? Why would that happen?
Yeah, so it could be because of resistance, so you're not getting rid of a lot of sodium, but the animal's taking in a lot of free water because you've offered free choice water in the cage. I think that's actually more important and happens more frequently than what we really expect. And the reason why I say that is because in a number of the studies that we've done, including one that we did a number of years ago, that Carrie Lockman helped do, and a lot of our Penn research interns helped do, where we actually hospitalized animals for 7 hours after giving them their oral dose, and we actually collected all of their urine. And so Eva LaRouche-Labelle was also one of those, and they extremely rigorously collected all the urine from outside. If they peed on bedding, we had weighed the bedding, so we had a reasonable idea of how much urine volume they got rid of over the 7 hours. And we were able to quantify how much sodium and look at urine sodium concentrations. And amazingly, 2 of the 7 dogs that came in actually left heavier and probably with more fluid than when they came in, despite getting their oral diuretics. And they were 2 dogs that drank copious amounts of free choice water. So they're like super thirsty. So they drink a ton of solute free water, and they basically just dump that back out again. And in those 2 dogs, they actually left with more water than what they came in with, because of the amount of compulsory sort of water drinking that they did.
I was going to ask, do you think that's like a psychogenic, I'm in hospital and I'm a little worried by everything, or is this a vasopressin response or imbalance?
Yeah, it's really hard to know. Is it because, right, the animal's in the hospital, it's nervous, right? And one of its reactions is to drink a lot of water. Or for whatever reason, as you're diuresing that dog, its thirst sensors and stuff are a little bit reset or out of whack, or, and they just they feel thirsty and they want to drink a ton of water. How or if that happens at home is really hard to know. We always ask owners, is your dog drinking more water and urinating more? And then we take that as a good sign that they have good diuretic responsiveness. If this were a dog at home that was drinking a ton of water and urinating a lot, we would interpret that as it was a great diuretic response. But we know in these two dogs, they had the worst diuretic response of anybody that we actually quantitatively measured. So it happened in 2 out of the 7 dogs that we hospitalized. So does it happen is it occurring in 1 out of 3 dogs out there in the real world? I mean, who really knows? But I think it does. I think it has to be happening somewhere out there. It would convey to you and I, as we're checking that dog, a false sense of efficacy. Because the owner says, oh man, he's drinking a ton of water, he's urinating a lot. And then we're like, yay, he's decongesting. He's got great responsiveness, right? But all he's doing is really dumping out free water. And dumping out free water, they're just going to get dehydrated. They're just going to deplete water from, their intravascular space. And so this difference between dehydration and congestion in terms of, are you resetting the distribution and the balance of interstitial sodium in water to intravascular sodium in water, I think is an issue. Just getting rid of free water is not very effective. And the only way you're really going to know that is by coupling it with the urine sodium. One of the questions we ask our residents now is not just, are you getting plus on your ICU monitoring sheet under urine output, but what exactly are they getting rid of? So yes, it's plus, but let's couple that with a urine sodium and make sure that we believe they're getting rid of a lot of sodium. If it's plus, and the urine sodium comes back as 20, we're probably not doing a great job at decongesting that dog.
Can you tell us more about that? Because you have this recent paper exactly looking into that, spot urinary concentration. So what's your current protocol? How frequently do you measure urinary sodium? When do you measure after you start furosemide and so on? Do you have a protocol, or what's your approach in your clinic?
I'm not so sure we have a protocol in that, your ability to get the urine sodium is dependent on when the dog is going to urinate and the dog's stability for you to go in there. And, frankly, your desire to get one, right? So you can wait until you get a free catch sample. If you were super aggressive and the dog was amenable enough, maybe you would cysto the dog, or in a real extreme case, maybe you would actually do ins and outs and catheterize the dog. What I will say is that I think it's a very reasonable practice to uniformly attempt to get a urine sodium by whatever means you can, right, after the dog is hospitalized and after the dog gets a dose of furosemide. The study that we did that was, retrospective, the timing of when we got that urine compared to when the dog came in and how much Lasix it had gotten and the timing from when the last dose was all over the place. Yet, despite all of that sort of quote unquote noise in the system, there was an extremely strong relationship between that urine sodium concentration whenever you happened to get it and their ability to get out of the hospital and the time it took for them to get out of the hospital and the risk that they had of dying in the hospital. So that noise makes it hard for us to think about real tight pharmacologic and physiologic sort of connections. But the looseness of that relationship also is good in terms of its effectiveness, in that for our residents, look, getting a urine sodium anytime within the first 12 hours after they're hospitalized, is like a win for us. And so you could still use that and rely on that to give you some idea about their diuretic responsiveness. And so I would encourage folks for acute heart failure to attempt to get a urine sodium, sometime within the first 12 hours so that you can make decisions on that without having to wait the conventional 24 hours right before you know whether or not the dog is responding or not. So that's what we want to try to get rid of. If you get a urine sodium 6 hours in, typically that dog still is in oxygen. And if you did not have that urine sodium, what would you tell your resident? You would say, okay, keep doing what you're doing, and let's see what its respiratory rate looks like tomorrow morning, 18, 12 hours, 24 hours from
Right.
now, and get some radiographs. Right. And that's your first real check of whether or not you should start changing your therapy. The urine sodium would suggest, hey, if I get a urine sodium that's really low in the first 6 hours, my chances of me coming back in 24 hours and that dog being decongested are probably not super high. So what I should do is I should intensify my therapy now so that I increase the chances 24 hours later that the dog is going to be decongested. Again, that's an extrapolation from the data that we got. We didn't 100% prove that, but that would be the logical sequela of the or consequence of the data that we did get. So yeah, I mean, our residents do that now. They would look at a urine sodium, and if it's really low, they wouldn't wait 24 hours to do something. They're going to intensify the therapy, whether that's more diuretics or whatever.
It's a nice idea, isn't it? And from a practical perspective, let's say people listening to this say, oh, actually, I'm interested in doing this and getting a feel for this as a measurement in my clinic, in my hands. You can just run a urine sample on the electrolytes machine, on the standard blood gas analyzer, something like that.
Yeah. So my understanding is they put it through the regular biochemistry analyzer.
Yeah.
Although they sometimes have to dilute it if the urine sodium is really high, they would dilute it.
Yeah. Okay.
Whether that holds true for all machines, especially the point of care sort of pet side machines, I don't know.
Yeah. It would be sensible to check with your machine supplier, wouldn't it? I think before embarking. But it sounds hopeful that there's something within reach, rather than it being something that has to be sent on ice to a lab or something like that, which obviously makes it highly impractical for those acute scenarios.
It makes so much sense that we look at sodium chloride. If you are using a diuretic that gets rid, wastes sodium chloride and potassium, and it makes a lot of sense that we look into sodium chloride, as you said. What I wanted to ask you is about sodium intake, dietary sodium, because invariably clients will obviously ask us, vets will ask us, okay, how much sodium restriction should this patient in heart failure have? And as sodium is maybe one of the most important electrolytes. What's your approach with dietary sodium? Once patients develop congestive heart failure, what are your recommendations to your clients and referring vets about dietary sodium?
We don't have a huge amount of data on this either, and it's also very controversial, I believe, in people, not only for heart failure but also for hypertension, in terms of how much dietary sodium really makes a difference. And when you talk about sodium restriction, like what does that mean? Like how much sodium is restricted? Clearly the vast majority of sodium that you get is through diet, right? And so it makes sense to think about restricting that, knowing that if you're super severe about restricting it, that might be counterproductive to you, in that it's going to further intensify neurohormonal responses. Maybe it makes you even more resistant to diuretics, in that your body now is so the sodium avidity in your body is so high that you start running into problems in terms of diuretic resistance. So, in the absence of a lot of hard data, I kind of bail out, if you want to think of it that way, and just go with, the quote unquote sort of moderate restriction. I still use this great table that Lisa Freeman at Tufts had, where it shows you the sodium content of a lot of the different commercial diets out there. And she breaks them into like really restricted, moderately restricted. And I forget what the exact number is, but it's a certain amount of sodium right per kcal that's in this sort of moderate range. And so we typically have owners, sit somewhere in there. We certainly tell them, like, don't be feeding your dog, hot dogs and beef jerky, like stuff that's packed up with sodium. But the relationship between when the dog eats, what its urine sodium is going to be, right? There's obviously going to be a connection there. And so that's one of the studies that we're actually really interested in doing. And that is, let's say that you are asking an owner to occasionally collect urine at home, right? And, send it in or for us to try to figure out what the sodium is. I believe it'll be very connected to when the dog is also eating. So one of the studies that we're trying to do is see what the daily variation in urine sodium is with the dog at home over the 3 times that it pees during the day, and try to correlate that back to what the dog is eating and when and what sort of medications the dog is receiving. Because I think there will be some variability. Can that variability range from 60 to 300, or can it range from 50 to 100? Like we don't really know that. So that's one of the missing pieces of information. So that answer got a little bit rambling there, sort of off topic in terms of just urine sodium. But yes, the diet clearly is the input arm of the system. And so it must play some role. That role, at least in my mind, is really hard for us to sort of figure out, but it undoubtedly plays a role in what sort of urine sodiums you're going to measure. Is the diet enough to take a dog who's very, very dilute all the time and turn it into a completely normal urine sodium? Or does it stay relatively dilute and maybe go from 60 to 90, right? Or does it go from 60 to 150? And that I just don't know.
I love the idea of assessing early for resistance. Let's think specifically about a patient that is not showing a furosemide response. I guess I have two questions related to that. First of all, is do you ever see dogs that are naive to loop diuretics and you start them on furosemide and they just don't respond, or they don't respond anywhere near like you would expect them to, but they do respond to torazamide?
I think we do occasionally have dogs like that. I think those dogs are not super common. I think it's more common that later in the course of disease, once they've already had, chronic exposure to the loop diuretic, that you go from 4 to 7 mg per kg of Lasix, and you ask the owner, is there any change in urination and drinking habits at home? And they tell you nothing has changed. But then when they go on to torsemide, they're like, oh my God, there's so much drinking and so much urination, right? There's a huge market change. Personally, I think we experience that more in the later stages versus early on in the naive dog.
Okay, great. And my second question was related to that move from furosemide to torsemide. Are you a layering person or are you a switching person? Because I've always been a switching person, and I was lecturing on this a couple of weeks back, and I presented what I call the John Rush method, which is the layering method, and the Mark Oyama method, which is the switch. And everyone said, well, why do you switch? And I said, well, it's what Mark Oyama does, so it can't be wrong. Is that still true? And how's your approach? How much do you worry about things like azotemia associated with that?
For sure. I think it's 6 of one, half a dozen of the other. And I think that, if residents come and ask me, like, should I switch or should I add? I think it's a very individual sort of case, and it depends on the history. And some of it depends on, even things like, do I trust that this owner is really observant at home, right? And is going to catch that the dog feels a little bit off and, didn't eat as well today, and is going to let us know, versus an owner who is not as in tune with that, right? And is going to wait until the dog is like lying limp on the floor and is like a little shriveled raisin before they call you. They think something is wrong. And so, yes, I think we do have animals that switch over, right? Everybody's conundrum there is, what's the conversion? Is it 1 to 12? Is it 1 to 10? Is it 1 to 8?
Yeah.
So some of the residents feel more comfortable keeping them on the furosemide and then just introducing a quote unquote subtherapeutic amount of torsemide, right? A dose of torsemide that's a lot lower, so they don't have to worry about this conversion factor as much. So I think either way is not unreasonable. And it really is just you start doing it and getting a feel for what the sort of response is. One thing that we are a big proponent of here is sequential nephron blockade. And so, historically, that's been one of the first things that I've done or sort of encourage our residents to do. And that is add in a quarter dose of, a thiazide, of L-dactazide or something. I think anecdotally, the owners will tell you that there's at least more PUPD, polyuria polydipsia. And hopefully that means better congestion, like although we've said, right, what's the limitations of that? That's a strategy that we use a lot. And I know that there's, folks out there that don't do that because in their experience, it causes a lot of azotemia and renal injury. We experience that very, very infrequently. And maybe it's because of the doses that we use. So we're not using anywhere near 2 to 4 mg per kg of thiazide like you would normally use if that was your only diuretic. We're using 0.5 mg per kg a day or 1 mg per kg a day, or sometimes we even do, 0.5 mg per kg every other day.
I'm super cautious if I go for the thiazide route. Absolutely.
Yeah. And, again, anecdotally, the owners will tell you that a lot of times the dogs are urinating more, right? The beauty of the urine sodium is that we would have to guess less and we could test our sort of hypothesis in that, sure, we could give 0.5 mg per kg of thiazide once a day, recheck the urine sodium. And if it hasn't changed at all, then okay, let's not do that. And now let's switch to furosemide, right? So the beauty of the urine sodium, if it comes to fruition, is that you could do something to give yourself an idea of whether or not your strategy worked, rather than just simply saying, I think this is going to work, and I hope that the next episode of heart failure is pushed back, although I will never be able to prove that. So
I suppose I hadn't thought about it much until I was reading recently some of the work on assessing diuretic resistance in people. And we're really late to that party. And I think of the cases where on a Friday, I've said, oh, hey, let's just push the dose up a little bit, or let's add in this or whatever. Give me a call Monday and let me know how he's doing. And they come in through ICU on Saturday night because they're dyspnea. Can you think, oh, I missed an opportunity there. And it'd be really nice to have something in our toolbox that we could reach for to help those guys, or rather to help us know if we're being effective or not.
Yeah, there's 2 scenarios there, right? So the one scenario you say is that you were not effective and it led to that, dog having an episode of heart failure, and you're reasonably certain, right, that your therapy was not effective because the dog ended up in heart failure the next day. But you also have these situations where you are doing something and then 2 months later, right, the dog has an episode of heart failure. What you don't know, because of the duration there, what you don't really know is, when I made that change, did I change it from 1 month to 2 months? Right? Did I change it from the next day to 2 months? Or was it always going to happen in 2 months and nothing I did actually even made a difference whatsoever?
Yeah, sure.
Right. And we never will know that. We'll never know what the counterfactual is in terms of what would have happened had we not done anything. So we like to think, and it's natural to think, okay, well, I bumped up that dose of diuretics. And so, yeah, that was a great thing to do. And it's probably going to help and just keep that dog out of heart failure. But there's no way to verify that. And so that's where you have to have some of the clinical trials. And that's where you have to correlate it back to the urine sodium so that you can say, well, yes, when I do something and I make the urine sodium go from 60 to 120, I know that that is correlated with less risk of heart failure in the future. If I do something and the urine sodium stays at 60, I know then that I should do something different because I haven't changed the risk of future heart failure. Right? That's the sort of dream that
we want to see the future.
Yeah, I mean, that's the sort of dream that we all have, right? About how this would work. Like any system, it's imperfect, but it works reasonably well in people. Yeah, and so it would seem to, be something that we can use in dogs.
And it feels attractive, doesn't it? If, let's say, the owner submits a monthly pooled urine sample over a couple of days, or I don't know what that looks like, but to their primary vet, they check the urine sodium and say, oh, it's dropped this month compared to what the average has been, or it's reduced by 70%, and previously it reduced by 10 or 10. And then we can get ahead of it. So actually using it as a monitoring tool is a nice idea, long-term as well as short-term, to establish the impact of our decision-making.
Yeah, theoretically, right, that would be so much more effective than what we currently do now. And the dog gets rolled into the hospital. We take an X-ray, and we're like, okay, well, I think everything still looks pretty good. And on the X-ray, and the veins aren't really super big today. And it would be fantastic if the owner could collect that urine at home, send it to you. It avoids having the dog come in and have a hospital visit. It avoids having to do a radiograph unnecessarily, at least, in the US, where we do radiographs like the residents sometimes are like, okay, I come in every 3 months for a radiograph. And I'm like, okay, well, is that really like a great way to monitor? So
I'm
yeah,
sitting here thinking I don't take enough radiographs. It's it's the opposite problem.
Yeah, if you roll that dream forward even more, right, and the urine sodium that we're getting is really a reflection of how well we're diuresing and how well we're getting rid of interstitial sodium, right? So that's the connection you want to make. So some might say, well, let's even get closer to the source and like let's actually measure what the interstitial sodium is. So I think that is not an unrealistic dream, right? If you think about Freestyle Libre and
I was going to say we do
measuring
with
interstitial glucose and stuff like that, like how far off is it where you could have real-time monitoring of interstitial sodium and have that guide, medication just like interstitial glucose is guiding how much, diuretics you get. 100%, right? People on the human side are looking at that. There's no doubt about that. People are thinking about, monitoring devices that will measure your interstitial sodium, and there's interest in that on the dog side as well, for sure. But that's another
very
monitoring
cool.
thing that you could totally think about.
Yeah, that would be really, really cool. If I can just ask you a quick question, still about furosemide dose. Because we still use furosemide as a rescue diuretic. We use furosemide when we believe that we have resistance to furosemide doses to furosemide. I have to say that we are lowering our threshold more and more because I think the compliance with furosemide is better. The tablets are easier to split, to score, and so on. So a lot of times we end up changing to furosemide even before we have clear signs of furosemide resistance. But my question is, we still, based on, in fact, your initial studies and so on, we still use furosemide BID. So I would calculate the total daily dose of furosemide. I would use around 1/10 to calculate the furosemide dose, and then I would give that dose BID. Now, based on all the stuff you have studied, pharmacokinetics and pharmacodynamics, does that still make sense? Or we should just use it SID even in late cases?
I think that's perfectly reasonable to take the daily dose and split it. I mean, the dog's already getting BID drugs most of the time, right? In terms of its pimabendin and the ACE inhibitor potentially, right? One of the big pseudo causes of diuretic resistance is compliance at home, is the owner's struggling to give all of the medications that we're asking the owner to give. So if going to SID makes the compliance better, then I'm all 100% for that. If the dog is an easy goer, and takes the medications like a champ, then splitting it into a BID, I think, is perfectly reasonable as well. I think you can be effective either way. We don't know this as a solid fact, but I think we would all agree that you have our confidence in doing that with the furosemide, going to SID furosemide, we're a little bit more hesitant about, simply because, you're going to have a good portion of the day where there's no diuresis happening whatsoever. If you go to SID furosemide. So yeah, Jose, I think that's perfectly reasonable. In fact, I'll be honest with you, is that most of the time when we use it here, we're doing what you're doing, and that's splitting it into a BID dose.
Okay, cool.
So if you have a Labrador who will eat the tablets, you're good for BID. If you have a Chihuahua,
I think that's perfectly reasonable. The big question is, the conversion. If you're going to wholesale go from furosemide to torsemide, right? Is it 1-10? Is it 1-8? Is it 1-20? The stuff that, usually guides us is some of the pharmacokinetic stuff that was done, again, it was done in healthy dogs, but it would suggest that the conversion fluctuates. There's a dynamic conversion rate there that's dependent on the amount of furosemide the dog is receiving, such that at the lower daily furosemide dose, the conversion rate, might be 1-8 or 1-10. As you get higher in the furosemide dose, let's say you're out at now 8 mg per kg or 10 mg per kg, it would suggest that the conversion is going to be a little bit lower, and the conversion might be as much as half of the original conversion. That it might be, you can get the same amount of diuresis at 1-20. I guess we would be more conservative with the conversion rate in animals that are on higher and higher doses. versus
Really
those that are
interesting.
naive or on very low doses. And I think most people are probably attuned to that sort of thing and change their conversion.
Yeah, that's great to hear. That's exactly what we tend to do. Can I ask you? So you talked a lot about about measuring sodium concentration in the urine and so on. I'll be also interested to know, how do you assess the serum levels of sodium and potassium? Because when I look at the electrolytes, well, I have to be honest, in the past 20, 15 years, I would look at potassium. And I think, are they hypokalemic? Yes or no? Do I need to worry about potassium? And I would only look at potassium. Then with your work and Darcy Adin's work, then I start looking at chloride. But I still look at sodium and chloride like, okay, if they are low, I would think, well, this is an advanced stage of the disease. This is dilutional. This is probably dilutional hyponatremia and hypochloremia. But then I'm a bit stuck. So what shall I do then? Does this mean that I need to intensify my diuretic therapy? Could you please guide us? How do you look at the electrolytes on like bloods from a dog with congestive heart failure?
Yeah, I think it's really, really difficult. Your questions are really great one, and it has multifaceted in that. What's the meaning of the electrolytes being low? Is there a differential interpretation between the sodium and the chloride in terms of their level? And then, if either or both are low, like what should that trigger? What should you try to do about that? And I think the range of opinion is very wide here. I think that there's sufficient amount of data on the veterinary side that we know it's a bad prognostic sign, that those animals are at higher risk for morbidity and mortality. So I think we feel reasonably comfortable with that. I'm not entirely certain we feel reasonably comfortable about the information that sodium is going to give you versus chloride, right? If sodium is normal, but chloride is low, or vice versa, or they're both low, or one is like really, really low and one is just kind of like medium low, like what the sort of interpretation there is. But I think the argument that Darcy makes is a real compelling one, in that, yes, it's sodium, chloride is its buddy. Like, so in some respect, sodium is like the left ventricle and chloride is like the right ventricle, where everybody sort of ignores the right ventricle and chloride. It's just like it's a little tag along friend. But from a physiology sense, at the sodium chloride exchanger and stuff, right, there's 2 chlorides for every sodium.
Right.
And in the macula densa, it's the chloride that's being sensed. It's not the sodium that's being sensed. It's the chloride that's driving the tubular feedback system. And there are some papers on the human side that would suggest that chloride is a more powerful predictor of mortality and stuff than the sodium. If the chloride and sodium are low, or one or both are low, we would interpret that as a bad prognostic sign. In some instances, that might trigger us to take what we think is a relatively, a stable animal and intensify its therapy in order to try to address what we think is quote unquote impending congestion. Again, the number of times where we can prove that we're successful in that, I think, is low. In that, I don't know about you guys, but we almost never make a hyponatremic or hypochloremic animal normonatremic or normochloremic by changing its oral medications. There's some argument for people, I don't know how much traction this still has, but there used to be a school of thought that you should actually add back in some dietary sodium to animals that are really profoundly hyponatremic and hypochloremic, because you're trying to correct the really hyperstimulation of renal sodium avidity and activation of neurohormonal axes by having that really low sodium, right? And to add a little bit of sodium back into their diet, or be a little bit more lenient about, if they're on a sodium restricted diet. Where I think the urine sodium could help you is it could help you sort of navigate some of that. And that is, if it's hypochloremic and hyponatremic and is really low urine sodium, then yeah, you probably don't have great natriuresis. You might have a lot of diuresis and free water excretion, but you probably don't have really good natriuresis.
Do you think it depends on context? I'm just thinking about my approach as you're talking about it, and I think for me, a dog that presents with, say, tachypnea, maybe some ascites. They're really congested. There's no doubt about that. And they're hyponatremic, hypochloremic. Okay, I'm concerned about that. I guess that's one context. In another context, if you have a dog whose respirate's a little high and they're on 6 mg per kg furosemide and their chloride is below normal, I think, okay, the furosemide's doing something. I guess I'd look at it and think it's a diuretic effect in that case. But maybe I should be more concerned. The reason I mention that is I often tell my residents, or have often told my residents over the years, maybe I need to correct it, that if you've got a dog who has got a very solidly normal chloride and is tachypneic with pulmonary edema and has a solid dose of furosemide, so 6-8 mg per kg, that's evidence of resistance. I would want the chloride to run a little low to show me that diuretic's working. Is that the right way to think about it, or is that missing the mark?
I don't know. So the question would be is the serum sodium concentration really reflective of, one, total body sodium content, and two, what's happening in the interstitial space? How sensitive is that? So, if you're diuresing, if you're giving them natriuresis to the point where you're making their serum sodium low, what does that mean for what the rest of the body compartments are, and what's the distribution of sodium and water in the rest of the body compartments?
Right.
And how much natriuresis do you actually have to have before you would deplete the body sodium such that, right, it couldn't normalize what's out in the serum? So my gut reaction on its face, I would say, I'm not entirely certain that would be a metric that you're really effectively causing good congestion. What that might suggest to me, rather than the sodium being excreted, another possibility for that is that a dog is drinking a ton of free water.
Okay.
And is just, taking in tons and tons of free water in the cage and is
just diluted
out. Yeah. So I don't know. I don't, those are two different situations there.
Yeah.
With the chloride, I think one of the aims to correct the chloride concentration is that one, to understand if the hypochloremia is caused by dilution or by loss of the loop diuretic. And so my understanding is once you correct chloride to sodium concentration, if the chloride does not normalize and is still low, this would suggest loop diuretic loss versus pure dilution. So we have been playing with that formula once after Dr. Addins published it, and I think as her data showed, whenever we correct, we never normalize chloride. It's still quite low. And then our assessment is, okay, there is both dilution or hypochloremia and loss caused by the loop diuretics. With this, and as you talked about sequential nephron blockage, would you ever use diuretics that would target the proximal tubule, especially if we are dealing with diuretics that may spare chloride, like acetazolamide and so on, which apparently is a hot topic now in humans? I have no experience. I've never used acetazolamide ever. But would you do that? Would you say, okay, based also on sequential nephron blockage, now we want to target the proximal tubule, and doing that, maybe we also bring more chloride to the system? Yeah,
it's funny how things have kind of, come around in that. When I went through vet school, and even, as recently as 3 or 4 years ago, right, when you taught diuretics to the students and stuff, you just gloss over the proximal tubule ones. You say, well, they're not effective in heart failure because the downstream, we can't segments of the nephron can do it. And until very recently, when they asked us to talk about heart failure therapy, we would pawn off the proximal diuretics to the medicine people, because it'd be like, well, there's no sense of having these in a cardio lecture. Right. And so the SGLT2 inhibitors, right, the sodium glucose transporter inhibitors, right, has changed that narrative like 180 degrees. And right, the evidence for benefit of SGLT2 across many different etiologies of heart failure is extremely compelling, and is going to be the next big treatment arm strategy that's going to come out in veterinary medicine. I think probably for both dogs and cats. It's just so effective in people that it can't be ignored, the veterinary potential of it. And so it's made us rethink, right, the value of these proximal tubular things. And even, something as old as acetazolamide, right, has gotten new birth with the studies that have come out that have shown, the really high profile studies that have come out, right, that have shown that there's some benefit in doing it. So, there's been a renaissance of these proximal convoluted tubule things. And that's the next huge frontier for veterinary medicine here. I think this is going to be the next, right? Drug companies are extremely interested in it. Veterinarians are interested in it. The lay public is interested in it because they see the press, or they have had experience with friends and family, right, on the SGLT2.
Right.
What's fascinating about that is that it does all these great things, and nobody really is sure why or how it does these great things. There's all these pleomorphic effects, and there's any number of different mechanisms and pathophysiologies that can affect this. But, it's one of these things that works great, and nobody is 100% certain like why it works so great.
We're super happy it works.
Yeah. But
let's not ask too much. Yeah.
But, it's a great fertile field for not only looking at clinical outcomes, but also mechanistically, right?
Right.
How are these things affecting pathophysiology of heart failure? And what can we learn about pathophysiology of heart failure by sort of working backwards? We know this works. So how does it work? And what does that tell us then about the pathophysiology of heart failure? How does that inform us about things that we, weren't really concentrating on, whether that be antioxidation or, immune and inflammatory things, right, that maybe are more important that we never really paid attention to. So yeah, that's all part of the sequential nephron blockade in a way, shape, or form. Yeah, super, super exciting. If I were just starting out in veterinary cardiology right now, that's an area that I would for sure, want to concentrate on, being somebody that's interested in heart failure.
Yeah. It's really nice to have something that's completely new to the field.
Yeah,
it?
Right.
To bring that in. I think that's really exciting.
Yeah, it's so interesting and novel and unique, and offers a strategy and a target in heart failure that has not been addressed.
I've got a question about cats, if I may.
Sure.
So we often laugh that we direct the conversation to cats because both of us are kind of feline interested. But I'm going to blame this one on you, Mark, because you talked about cats. Final question on furosemide. Is it something you reach for in cats? And if so, when?
Yeah, pretty obviously way less frequently than in the dog. And that's simply because we're, again, scared of over-diuresing and dehydration, and the cat's propensity to have, underlying renal dysfunction already. And, whether it's true or not, we feel like we have less room for error in the cat than we do in the dog. And so I would say pretty infrequently. One thing that we do a lot of, both in the dog and the cat, would be to teach owners how to give a sub-Q injection of furosemide at home. And anecdotally for us, again, the owners report a restoration of polyuria and polydipsia. And, that's another form of diuretic resistance. It's just oral absorption. So, another thing that we didn't really talk about that bears, it's worth mentioning is one way to help sort of sort out the cause of the diuretic resistance or low responsiveness, so that you can actually specifically target that cause would be, not only urine sodium, but if we were to measure one or the other or both, serum furosemide and urine furosemide concentrations, because they give you extremely useful information about why an animal is not responding, or, what's that animal's sort of status. The information that you get with the combination of those things can tell you whether or not an owner is getting the drug like they say they are.
Right.
Whether there's oral bioavailability problems, whether there's intrinsic problems within the kidney to respond to the diuretics, and whether or not there's appropriate excretion of, or, if you want to think of it, transport of the furosemide that's in the bloodstream into the nephron, into the lumen of the nephron.
Which is what it works, right?
Right, which is, and it has to be able to go from blood through the organic anion transporter in the proximal convoluted tubule to get into the luminal space in order to bind to the receptors there. Any one of those can go wrong and they get treated differently, right? And so one way to individualize and personalize diuretic therapy is to have a better understanding of where is the animal across that sort of spectrum there. And so that's a really important component. And wherever we can, when we're doing these studies about urine sodium, we're attempting to couple that with, simultaneous urine and serum furosemide concentrations so that you can better interpret the urine sodium concentration and find causes. So that's a really potentially powerful mechanism to really hone in on any individual animals. Where are they in terms of their diuretic responsiveness, and what in this very long line of things that have to happen, where are things not happening the way they're supposed to, be happening?
My mind is blown a little bit by that. Yeah. I think that would be a real game changer to understand where's it going wrong.
Yeah.
Fantastic stuff. Yeah. So logical.
Yeah, it's fascinating, but then it's a bit frustrating, isn't it? That we just play with doses. We just say, okay, let's give a bit more furosemide, let's add another diuretic.
Because this conversation has really made me think. At least I am just guessing, right?
And absolutely. And this is fascinating, but it reminds me of the RAS. You start reading about the RAS and you get more and more.
Right. You go down the rabbit hole of all sorts of things.
It's
a little bit, it's a little bit overwhelming almost to think about all the different things. And so, for the researchers that are interested in this, we're just trying to do just small incremental information, right? So retrospective look at things, and now prospectively look at things, and now trying to look at the daily variation in dogs with their urine sodiums are depending on their diet and stuff, right? And just start stacking information to the point where we can, inform really good randomized clinical trials going forward, and to design those in a way that we're going to get the information that we really want to get, and that will change practice habits, right? And having said all that, we gave cats the short shift there again, and that I said, well, we don't really do anything in cats. All we do is switch over to. But the SGLT2 promise in cats is there for sure. Right. And all the other stuff that's happening around HCM, right, is super exciting. And you guys probably have, if you haven't done already, I'm sure you'll do stuff about the myosin, stuff, and mavacamten, and all those really great revolutionary things that are coming out for HCM.
We had Josh. We had Josh as one of our guests, and again, mind blown. Fantastic potential.
That's another huge fertile field of research that
amazing.
Hopefully, young researchers will get on board with and really drive for. That's a really exciting area as well.
Mark, thank you very much. This was really outstanding. We have a tradition in our podcast to ask our guests to maybe give us 3 take-home messages from our conversation. If you would pick, could you choose 3 things that you think are important for our listeners to remember after this podcast?
I would say, even though it's imperfect, I think there's value in however you want to try to start doing it. I think there is value in looking at the urine sodium concentration. And to do that in a way where you're simply trying to get information, a piece of information, just like you would use a BUN and creatinine or a PCV or whatever. In that, we're not trying to say it's the be all end all, but as you get more experience looking at the range of values that come in on your animals, and you matching that up with the clinical state of that animal and what happens to that animal and your treatment, I think that's incredibly valuable experience that will start to have people think about the potential and be more familiar with the urine sodiums as we get more and more information and move towards, practice guidelines and evidence-based sort of thing. So I tell the residents all the time, there's no reason not to get it if you can measure it, and just use it along with all the other information that you have, and start to get a feel of how you might incorporate that into your treatment protocols. I'm all for 100% for trying to get urine sodiums. And then if you do nothing else, then look at it and have in the back of your mind, boy, it's kind of low. I'm not going to do anything different, but boy, it's kind of low. And having that in the back of your mind and seeing what happens to the animal, or telling an owner it's kind of low. I'm not going to change anything, but I'd like for you to be more vigilant at home about watching, because at least in people, this would suggest that the risk of heart failure is relatively high, right? So if it does nothing more than alert the owner to be more vigilant, or maybe you're more vigilant and recheck that animal sooner. So that would be one take-home message, that even though it's an imperfect science right now, we don't know everything about it. Getting a clinical feel for the urine sodiums, I think, is going to be extremely valuable for people. The other is to think about the promise and potential of urine sodium and urine furosemide, for that matter, or urine torsemide, for that matter, in terms of how that would customize individual care and give you information about that dog's diuretic responsiveness that up until now has been, not available to us. And to think about, if it all works out, how that could really improve outcomes and monitoring. And that's what drives the people that are interested in this. So that's what drives me and Darcy and other people that are interested in this, is thinking about that end sort of goal and promise about how you would incorporate that into everyday practice. And so for young veterinary cardiologists out there, or just young researchers out there that are interested in clinical research, this is a field that I think has great potential, and we need so much more information. A take-home message would be, this is a great area of research to be in. It's relatively straightforward to do. There's tons of people on the human side that would want to collaborate with you. There's tons of people on the veterinary side that would want to collaborate with you. So a great field, a great avenue of research. I think the last thing would be is that I'm very appreciative of stuff like what you guys do, and that is trying to disseminate information, trying to have conversations about information, and being real upfront with people about, hey, here's a whole bunch of different opinions. Some might be very right, some might be very wrong. But what's really interesting is to have the conversations and to think about the different possibilities and to talk about your experiences and stuff. And we don't get to do that a lot because we're a small community, and we do that at ACVIM, and maybe you do that within a small community of people that you are in your orbit on everyday sort of interactions. But I really admire the stuff that you guys do, and that you're trying to have a really broader conversation, a broader audience, bring in all sorts of people that have all sorts of different opinions. And again, there's some things that we might be very right about, and we might be proved very wrong about other things. But the exercise of having the discussion is really invigorating and refreshing, and I think can really move things forward. So kudos to you guys.
Thank you very much. Wow, I feel honoured you've said that. The
Absolutely.
For us, that open conversation is just super important as part of the learning, isn't it? And consideration of reflecting on your own practice, and how you could modify it, or actually think, oh yeah, I feel like I'm doing the right thing, for my patients. And that's a really nice, it's a real privilege to be able to do that, isn't it?
Yeah, for sure. For sure. The veterinary cardiology community is kind of funny, right? We're super small compared to everything else. But we're super small, but there's a huge diversity of opinion and experiences and stuff out there. And again, I think it's incredibly fascinating and interesting to hear what other people are doing and what their practice habits are. And then to think about, well, I do it this way, but why do I do it this way? And it's because Dave Sisson and Bill Thomas told me to do it this way, right? In many cases, right? And, why did they tell me to do it this way? And it was, what are the reasons for it? And then somebody else does it something different because Virginia or John Rush told you to do it this way, right? And it just gives you a chance to reflect about, like, what do we really know? What do we don't know? There's many different ways to do a great job doing veterinary cardiology. And that's another thing I tell my residents all the time, right? There is no one correct answer. Almost all the time, it's shades of gray.
Yeah.
Right. They're afraid. They come to you and they want the answer, and you tell them, well, you can do any number of six things, and they're all pretty good. So, here's the plus and minuses of each of the six things, and, you can decide what you want to do.
Yeah, in the UK,
very few instances do your residents come to you and they want to do something that is completely contraindicated, right?
that's super
It's always
unusual.
it's always shades of good, like, right? They're all good choices. We're just trying to figure out which is slightly more good than the other choice.
Yeah. In the UK, there's a bit of a buzzword in the veterinary community right now of contextualized care.
Yeah.
Doing the right thing for that circumstances of that owner and that patient.
Yeah.
And circling right back to what you've been talking about, this sort of individualized approach allows you to do that. Yeah. And it's not one size fits all, is it? And that's a fantastic thing to do. Thank you so much, Mark, for joining us. It's been a real pleasure and really, really thought-provoking.
Not at all. Thanks again for having me, and good luck with the rest of your podcasts and everything. And again, I appreciate the chance to come on and talk to you guys.
Thanks so much.
Thank you very much.
Cheers, as they say.
Cheers. Thanks again, everybody, for joining us and for listening into the Animal Heartbeat. Don't forget to click like or follow on the podcast streaming services or on YouTube. And please remember to follow us on social media to look out for any news or upcoming episodes on @heartbeat_pod. Thanks very much.
Thank you.